Hi. Hi, everyone, and welcome to our webinar today, Beyond Silica Towards Total Health. I am Dean. You find me in Melbourne, Australia. It is 11 a.m. in Melbourne, Australia, and I have Nayab with us, who I'll introduce more formally in a second, who is on the other side of the world. I believe it's 5 p.m. in British Columbia. Am I correct, Nayab?
Yep, absolutely.
And so we've caught each other at the right ends of the day, and we're going to have a beautiful chat today about everything related to silica. I'm going to be really clear that my specialty is definitely not silica, but yours is. So we're going to lean into you. I'm going to encourage everyone to please post questions if you've got them. We're going to even stop and pause if we find some great questions coming through and try and answer questions that you've got. But why don't we start with a bit of an introduction? I'm lucky enough today to have Professor Nayab Sultan. Nayab, I'm going to refer to you as, if that's
Sure.
okay. We've met a few times, so I feel comfortable enough to be able to do that these days. Nayab, everyone, is a global leader in occupational health and safety. Over 2 decades of experience specializing in absolutely everything around lung disease, such as silicosis, and silica-related conditions. You have a long list of accolades that sit against your name. I'm not going to run through them all, but I do want to note that you've been elected co-convener of the Developing Countries Coordinated Group under ISO 45001, which is a technical committee representing Canada. So maybe what I'll do is, before I introduce myself, I'm going to just lean into you and say, do you want to just give us a bit of background on yourself, what you're involved in today, and let everyone on the call feel the incredible experience that you've got and the impact you're having.
Well, thank you. Good morning, everybody. As Dean's mentioned, my name's Nayab Sultan. I'm originally from the UK, actually. That's where I was originally trained. I had additional training with the United Nations in various capacities as a labor inspector and factories inspector. So my background takes me back to the late 1980s when I really came into health and safety. And fast forward 30 plus years, as a health and safety professional, also qualified in industrial hygiene and occupational medicine as well, certified in occupational medicine in Southern Africa. Um, I realized quite early on that actually I was more interested in the prevention side of things. I saw the consequences of exposures to different things, injuries and accidents in the workplace, and I always thought there must be a better way, and prevention was the key, and that's what I've tried to concentrate my my interests on, and that's where the silicosis and the silica issue comes in. It goes back to an experience that I had many years back. But I'll touch upon that later on. Um, as Dean's mentioned, I've worked in various capacities, and I was just going to touch upon that ISO stuff. There is also there's a global standard. Most of you guys might have heard of it, ISO 45001, which relates to occupational health and safety management systems. And I'm involved in that recently. I represent Canada on that committee, and there's also a specialist subgroup on atmospheric workplace atmospheres, and I'm on the working committee for Silica. So very much now taking it away from being just a health and safety professional and then being an academic involved in the research of health and safety and silica, but also now working on the global scene to try and see if we can help put in place real good, robust systems to avoid issues from happening in the first place.
Amazing. So look, I'm keen for us to get going because I'm sure there's lots of people that want to understand more about our presentation today. But I guess just a little bit of background on myself. My name's Dean Mohr. I'm CEO and founder of My Occ Health Record. I've been in the world of occupational health for roughly 25 years now, starting with a business called Body Care Workplace Solutions, which is actually a health services business. With on-site physiotherapy, we do pre-employments, periodic assessments, health and wellbeing services into large organisations. 6 years ago, I decided it was time to change the way people were using data, and we wanted organisations to have better control and understanding of their health data. We felt that health professionals, or at least providers out there, were the ones with the systems, and organisations were typically losing their data or was ending up in spreadsheets on computers when they moved providers. So we really wanted to disrupt the market with My Health Record and really give the opportunity for organizations to own their own data to actually have good longer term impacts and longitudinal views over the health of their employees. And Silica is a space that we've definitely specialized in around our workflows. But enough about me today. Let's get going into it. I'm sure we'll tap on different things during the journey. So we've got four key topics today: silica risk and regulatory landscape, best practice control measures, health monitoring and data management, and then building a compliance roadmap. Let's dive straight into it. Nayab, there was a study put out by Curtin University in 2022 that suggested that 10,000 Australians are predicted to develop lung cancer in their lifetime from being exposed to silica dust. And roughly 100,000 workers will be diagnosed with silicosis as a result of their current exposure to silica. It's a very serious issue in this country. I want to start at the beginning. Can you talk to us about how people are being exposed, size of particles, materials, and the materials?
Sure. So when you look at silica as a substance, it's quartz, it's silicon dioxide. It's the second most abundant mineral in the Earth's crust after feldspar. You have it everywhere. It's right across the planet. Wherever you go, you will find it in some shape or form. It's even under the sea, right, with the sand that exists. So it's absolutely everywhere. And, it is a naturally occurring mineral. As I mentioned, what tends to happen, and I'll kind of try and explain it in apples and pears. I'm not going to talk at a very high level academic level. I'm just going to try and keep it very simple. There are probably several dozen types of polymorphs. A polymorph is like a variation or a version of silica. And there's loads of different types of silica. The one that we're particularly interested in the occupational setting, in the working environment, is alpha quartz or respirable crystalline silica, and the other one is amorphous silica. Amorphous silica is around us, but it's not as particularly harmful as the respirable crystalline version that exists. And when you look at it, I'll give you an example of amorphous. You'll get it in, say, something like soil, right? Soil dust blowing around, you will have amorphous silica there. It can crystalline as well in certain conditions like extreme high temperatures, but overall it's not as bad, but it does cause scarring of the lung. The respirable crystalline silica spectrum is where we're concerned with. You can find RCS, which I'll refer to it as moving forward, in so many different environments. You'll find it in sand, stone, granite. It's in different forms, in different formats. And there are various stones that have different degrees of quartz, i.e. the quartz component is the one that's particularly harmful. And I've got a couple of examples. That we have something known as Tripoli, that I believe is up to 95% respirable crystalline silica. Sandstone is between 70 to 90%. The engineered stone, the culprit that caused a lot of the concerns in Australasia, New Zealand, is between 90 to 97%. It's right at the very top of the risk rating in terms of the substances that are known to have high levels of quartz in them. And then the list goes down in rock dust and, mortar and shale and things of that nature. But the engineering stone is the one that just burst onto the scene. Now, the funny thing is, well, it's not funny, but it's been around since the 1960s. It was manufactured in in Italy, pardon me. And then it was sort of adopted by various countries like India, China, Israel, even in the US, and it's been called different things, but it's been around since the 1960s. And then it became popular over the last decade or so. You'd seen more of it being used in composite materials. So that's the crux of it. Now, silica as a substance, RCS, is also what's known as a group 1 occupational carcinogen. It's known to cause cancer in humans. The amorphous version is a category 3, which basically is not associated with cancer. So you can have different silica forms, and they may or may not cause cancer. The cancer that's most associated with respirable crystalline silica, as you mentioned, Dean, is lung cancer.
So
So,
just if I just ask then, so the health
mm,
impacts through the long-term exposure, do you want to just talk about the impact on the lungs, what's actually happening within the
mm,
lungs, what's changing and why does that matter?
sure. So one of the things that I always try and put a comparison on is people talk about asbestos. And when people hear the word asbestos, they panic. They think, oh my God, you can't in one lung full of stuff. Asbestos is a type of silicate. Silica dust is a silicate. They come from the same family, right? So in terms of the risk, they are slightly different, but the fact is that they are both known to be harmful to human health. With silica, it's more nanoparticle. It's 200 size of that sand.
No,
Yeah.
we're losing you a little bit with your internet. Let's hope it stays good there. Maybe just take a step back.
Okay.
Yeah.
I apologize for that. Maybe I'm talking too fast. I broke the internet.
You wouldn't be the
Um,
first. Our major provider went down this week in Australia, so it happens.
yeah. So what tends to happen is that because it's a nanoparticle, it's i.e. microscopic nature. I've had a little blip in the system. It's about 200 times smaller than a grain of sand. Now, a grain of sand is pretty small, and it's about 200 invisible. And that's one of the reasons why when I talk about the control thing, using sight to look at dust is not a good idea because you're already above the threshold. But when it is, the this dust, what typically happens is it will bypass the oronasal cavity. It'll go through, it'll go down, it goes down into the lung. It typically deposits itself in the upper lobes, but it will go down to where the gaseous exchange happens, the alveolar sacs. It's like grapes, right? So it goes down to the point where the grapes are, where the exchange of oxygen is. And what will happen is that the more dust that you're exposed to, the more that will get deposited down. One of the mechanisms of the body is to attack foreign bodies. So you have these macrophages, these little cells that go and attack. It can be a virus, it can be a bacteria, it can be a dust as well. And what will happen eventually over time is that that particle will go into the lung lining. Okay? There will be a chemical reaction, and then that part gets scarred, which is what we call fibrosis, scarring of the lung. And that's when you start having a reduction in your lung capacity, i.e., your breathing capacity diminishes a little bit. Now, obviously, the more you're exposed to, the more death of the lung tissue, and therefore you're going to have more complications. One challenge is with silicosis. Number one, it is completely preventable. But the problem is that um, it's a progressive disease. So even if you stop being exposed, the reality is that whatever dust has entered into the lung can continue to cause damage to the lung. And so that's why we call it a progressive disease, a progressive lung disease, and it can continue to cause chaos in the capacity of the person to breathe.
So can I ask then a
It's
question?
not treatable.
I just want to ask, so
Mm.
early diagnosis. So what are we looking for early? We talk about periodic testing required across this country. I'm interested in understanding, early are we looking for movement in markers? Like, how do we pick this up early enough to then mitigate risk moving forward?
So in Australia and New Zealand and in different parts of the world, we use the hierarchy of control, right? Hierarchy of control talks about elimination as the first step. And I would say that that is probably the very best measure to protect ourselves from respirable crystalline silica. But we live in the real world. We're going to have dust around us. So elimination is not always going to be possible. In fact, you can get it from the atmosphere as well, from if you live or work near a dusty farm or something like that, that can also have exposures, but that's a different conversation. But the truth of the matter is, when you are looking at um, when you're looking for early detection, I would step it back a little bit. I would say that I would come back to that early detection thing. The first step is to detect the hazard. If you detect the hazard, that's the best first step in the whole chain. Because once you recognize the hazard, then you can quantify it, you can review it, you can determine how much of what type of hazard is it, how much of it is there, how much you're being exposed to, how you're being exposed to it, etc. Now, question with early detection, actually with silicosis, I will come back to this point, and it ties in with something that we were talking about earlier in previous conversation, was there are three forms of detection that is used for silicosis. One of the first steps, and this is where a lot of health and safety professionals can actually step in as well, and workplace organizations. You can do an occupational history questionnaire. You do not need a clinician to review that. So basically, you're just asking, what kind of industries did you work in? What kind of environments did you work in? What kind of hazards were you exposed to? Certain forms may be medically sensitive, and then therefore health and safety or general people in the workplace may not be allowed to review that stuff. But the occupational history, believe it or not, forms one of the three pillars of diagnosis for silicosis worldwide. It's one of the principal steps. The other two steps are spirometry, which is the blowing into the tube, and you look at force expiratory volume. And the third one typically is X-ray, chest X-ray as well. And that ties into your health surveillance programs as well. So, but if you try to recognize a hazard first and quantify it, that will be the first best step in the whole chain, as far as I'm concerned.
Okay, so we've sort of touched on the early levels. We're sort of into topic two now, best practice control measures. You've jumped forward to that, which is great. Um, we've spoken about elimination, substitution. Do you want to just talk through all the controls and the value of them, the hierarchy of controls?
Yeah, I mean, basically, for those who are familiar with health and safety management, the hierarchy of control is a universal model that's been used for many years in various countries. We typically start with elimination at the very top. The idea is to really eliminate the hazard altogether. If you get rid of the hazard, you don't have anything to worry about, in essence, right? If it's gone, what's the worry? What's the concern? There isn't any, right? And because we work within the risk management space, that is the best step, the number one step. But as I mentioned, we live in the real world. There's always going to be some kind of dust around us. When it's in the working environment, it may be in different formats. It may be because you're cutting something, polishing something, scrubbing something, you're drilling something. It doesn't really matter what industry you're in, whether you're in mining, tunneling, quarry related activities, or even manufacturing or a non-manufacturing environment. We'll have it, right? It could be in the brick that we're drilling into the wall in, we're cleaning up the concrete slabs or something. You'll find silica pretty much in most of those environments. Substitution is a very good, obviously, secondary type of step. You can get materials which have lesser content of quartz, and I kind of mentioned some of those where there are certain things that have a very high level of quartz contained within it, as mentioned that this artificial stone, very high level. Well, if you actually look at it, if you use marble as a substitute in those countertops, marble's up to 5%. So you can see it's right at the very end of the spectrum, but it could be used for the same sort of thing. You may be doing your countertop. So it usually comes down to, preference in pricing or whatever, right? So, and then obviously there are further steps down the chain. You have isolation where you can isolate the hazard from the individual. And that's really an important step because any kind of exposure needs to be governed. Now, as an industrial hygienist or anybody involved in just general risk management, you know that the moment you have exposure to something, it's going to cause an effect somewhere, right? In this case, it's a dust. Dust is not really intended to go predisposed to have dust entering into them. So the isolation component is very good because it allows the opportunity the operation to continue. Example, I also in my day job, I have my international work in academia and international development, but in my day job as a health and safety director for a big drilling, uh, you know, um, ground stabilization company that specializes in drilling and mining and quarries and tunneling, etc. I'm dealing with silica all the time. Now we can't avoid drilling. We have to drill because we're going to do, maybe we're putting in boreholes, we're drilling in anchors, whatever it might be. We have to drill. So what we tend to do is we'll find engineering solutions where we're isolating the individual from the hazard. So we will keep them back, we'll do remote drilling. Or if we have to go up closer, we'll have dust extraction at the point where the dust is coming off, and also we will suppress it with dust as well. So we will use like an atomize or a deluge system where the dust is controlled as much as possible, so as far as reasonably possible. And then, other controls, engineering controls can kick in. It can be any variety of different things. The one that where your product in terms of my occupational health record comes in is within that space of what do we call it? Admin controls. Now, administrative controls can be permits to work, safe systems of work, SWPs, SOPs, SJPs, risk assessment, whatever you call them. It doesn't matter. They're fundamentally the same thing. Here is an activity. What are the dangers? What are we going to do about it? Right? And so those administrative controls try to regulate how you're going to do the activity in a sequence or a step-by-step approach. What I like about the software that you guys have, you have the industrial hygiene component and you also have the occupational health record component. That sort of ties into that hierarchy of control step. And then the step below that is the wearing of personal protective equipment, which includes respiratory protective equipment.
I'm going to jump in for a second. We've got a question which I want to bring up from Mark McLaren. So thanks, Mark. So let's bring it into our little chat here. So Naya, very helpful overview. What is your view on the use of respiratory protective equipment when the personal silica air monitoring at a workplace has been shown to be less than 50% of the WES and therefore not deemed as high risk exposure to RCS? And the frequency and duration of the CS processing is relatively low.
So, Mark, great question. What I would say, there's a lot of compelling research. I've been researching silica and silicosis and silica-induced diseases for many years. I, as also a practical person, have to work within the parameters of the law. I use standards like workplace exposure limits or occupational exposure standards or whatever you call it around the world. The reality is, the research shows that there is actually no real safe limit. We use the zero, for instance, here in British Columbia, we use the 0.025 milligrams per cubic meter as a benchmark. That's the actual upper limit. And that's based on an 8-hour time-weighted average based over like a working week. Most people think that if they keep the exposure below that level, they will be fine. And the reality is, yes, in theory, based on scientific research, they will say, yes, it is relatively safe for the majority of the population. But you have to remember one thing. when they do studies on developing occupational standards, occupational exposure limits, or workplace exposure limits there in Australia, a lot of it is done in laboratory conditions. It's done in pretty clean environments. It's based on an individual. I'm not trying to be racist or anything, but it's typically a white male, middle-aged, with full lung function and no occupational diseases. That person is not really the reality of the world of working people, right? Everybody has a different susceptibility. And so that workplace exposure limit might be okay for somebody. They might be able to reach it and exceed it, and it does nothing to them. But there may be somebody who'll just have a minor trace of it, and it could cause an adverse health reaction. So I do like having workplace exposure limits because it sets in motion controls like an exposure control plan. But I wouldn't put all my eggs in that basket because I know that everybody is an individual and everybody's going to react differently. Now, the issue of the RPE, respiratory protective equipment, last line of defense. Obviously, preference would be to go towards elimination or isolation or other engineering controls. My experience is that respiratory protective equipment becomes ineffective over a period of time. People are people, that we get complacent, right? When you're dealing with, say, asbestos, everybody's, absolutely petrified. When it comes to silica, people just, oh yeah, it's okay. It's just silica. It's just dust. Well, not all dust is the same, right? And so I would say that wear RPE, respiratory protective equipment, for sure, but do it in combination with other controls. Don't just put your whole dependence on just the respirator.
Yeah. I think the other issue there is obviously being fit tested and making sure that
Yeah,
everything, and there's
yeah.
always issues related to that. People's faces are changing. Um,
Can I
I'm going
just
to,
add? Can I just add to that a little bit?
yeah,
Just another point of reference with RP. When it comes to respiratory protective equipment, you have to also remember that there are different sizes: large, medium, small. A size that fits anatomically for a lady will be different from one that may fit for a gent as well. And then you do have to factor in stubble, dentures, glasses, things of that nature as well. So it's very easy for that to not become effective. And also then the issue of the correct cartridge or whatever it is. In here in Canada, we use P100 pucks, which are great for respirable crystalline silica, but not for solvent or other hazards that might be present.
yeah, great. So we've got another question. It sort of follows on from one I've got here, which is why is baseline health testing so critical? And what role does accurate, accessible, data play in protecting the workers? So I wouldn't mind you sort of touching on that for a bit, and then we're going to get to Harry's question, and I'll get Harry Wilson, who's popped a question into us.
So the baseline medical, okay.
Yeah, baseline health testing. Why is it so critical?
Health, okay. So most of the organizations that exist in the world are small, medium enterprises, mum and pop type operations. For those guys, health surveillance may not really be an option, right? When you go into the domain of larger organizations like mining corporations and big players, they will have an occupational health and safety department, maybe have hygienists, they may have even occupational health nurses or occupational physicians. In those environments, you're more likely to be able to capture data before people are exposed to hazards. I actually tend to take it a step back from that. I touched upon it a little bit earlier. You can have occupational history questionnaire, which anybody can analyze, particularly if they understand hazards within industry. When you step into the domain of having like a baseline medical, that for me is it's a fantastic step to have because I know what the health status of an individual is when they've joined the organization. Okay, Johnny here has had, lingering back pain issues. They've got, asthma, they've got, skin issues or whatever it is. But when it comes to the baseline, I am really concerned, particularly with silica. I want to know what their lung function is. I want to know what the state of their lungs is, right? You also have to remember another thing is that Silica exposure, this might be a bit confusing, but I'll say it. When you're exposed to silica dust, you inhale it, but it doesn't only affect your lungs, it may affect your body in other areas as well. We talk about silicosis, but actually there's silicotuberculosis as well, which is more towards the mining sector, which I might come back to that. But you can also get silica-induced diseases as well. And that is where your health surveillance program kind of recognizes that, hold on, you're inhaling something, but it's going to metabolize somehow. It's going to change form and it's going to come out somewhere else. Sometimes it comes out in your urine, and therefore you can actually have kidney dysfunction. It might affect the lung, as we know, we can get chronic bronchitis, emphysema, lung cancer, things of that nature. But it also might cause autoimmune conditions as well. Now, when you're doing baseline medicals, are you going to check for every single disease? You're not going to, right? It's just not possible. We're not necessarily geared for that stuff. So you concentrate on the big fish, which is the lungs. And then you monitor the exposure. Now, as a health and safety professional, I would look at the workplace exposure limit. I would see to see if my controls are effective or not. If my family hit or her lungs after 6 months, I see you frozen from this side. Hi, okay, you're
You see me, Nayab?
back. Can you hear
I
me?
can hear you now. So
Yeah, I can.
there you are. Got you back. I don't know what just happened then, but I've got you back.
All right.
Um, okay, so look, let
Yeah,
me.
I was just saying that, I would take uh, the baselines, um, in total. I would use that in combination with other stuff, like the workplace exposure, the exposure standard, whatever's the level of exposure and things of that nature. So not just a standalone
Yeah, and
thing.
look, Harry Wilson's dropped a comment here. Do you think health monitoring is effective for exposed workers, i.e., lung function, ILO, CXR, etc.? What would best practice be in your opinion? Wow.
Okay, you're back.
Wow.
I,
Brilliant.
I heard that question.
Where, where,
I heard the question based on
It was
I
the question
heard
around do you think health monitoring is effective for exposed workers? I
yes,
guess that's the broader question. Yeah, what
yes,
would be best
yes,
practice in your opinion? We all know best practice. Um,
yeah, yeah.
but I did have Mary O'Bell from New Zealand, Dr. Mary O'Bell, did make a mention before. She doesn't think it's enough to do baseline medicals, which I probably agree with. I think they should be
Mhm.
correctly
Yes,
interpreted and
agree.
acted upon by qualified medical professionals. You can't rely on
Okay.
HR to interpret results, which seems to be a
Okay.
broader issue, I would suggest.
Yeah, no, no, I
Let's get
agree.
back
I
to
agree
the
completely.
health monitoring and is it effective for exposed workers and what's best practice?
Well, with health surveillance, you typically have two types. You have biological monitoring and biological effect monitoring. Biological monitoring typically would include like the lung function testing, and chest X-ray, check your skin, check your hearing. That's the simplest, that's the simple type of stuff. On the other spectrum with biological effect monitoring, you can get into more complicated and more in-depth uh, measures, such as looking for biomarkers. Now, in depth, there are certain biomarkers that you can check for. There's CC16, Club Clara cell 16, there's IL CL6. There's various biomarkers that can be used. I think that the one that's exciting for me is there are a couple actually from around the world, but one that's come up in Australia, which seems to be building up traction, is the exhaled um, exhalation, right? They're looking at detecting changes in your breathing, and from what I've read, uh, we don't really have it here in Canada that much, but from what I've read from the basic literature, it's looking, for instance, in one of my jobs, I tend to be very busy. So in one of my jobs, I'm the occupational health specialist and so what we were trying to do was to try and find a point of use, um, low cost, high effectiveness, something similar to like a pregnancy test kit or the PCR when we were doing COVID tests. Um, the, the technology is out there, things are changing constantly. AI technology is coming in thick and fast. On another project that I'm working with University of British Columbia, we're using AI technology to do with the early detection of tuberculosis and silicosis amongst ex-mine workers in sub-Saharan Africa. Um,
Do you want to just
Silicosis is
elaborate on that a bit? Do you want to elaborate
hmm,
what you're actually doing? Yeah.
sure, sure. So, the Canadian Institute of Health Research basically awarded the university and myself a grant of $600,000 to work with a couple of AI medical companies to look at using uh, this this particular device that looks at the X-rays of individuals. Now, typically, what's tended to happen is silicosis would quite often be misdiagnosed. That was a big problem in sub-Saharan Africa and the global south. And you needed to be a B reader, and it's a certification, and somebody else needed to confirm it and use various parameters. It was still possible for misdiagnosis to happen, particularly misdiagnosis for tuberculosis because they look similar. So what's happening is that with this AI technology, it looks at the X-rays of the individuals, and with a relatively high degree of effectiveness, efficiency, it can identify early patterns that might indicate silicosis or some kind of silicotic condition or some kind of lung abnormality. If nothing else, it allows you to be triaged into the system to say, hey, this gentleman or this person needs to be looked at urgently, and they need to follow through with additional checks, whatever those examinations might be. It might be a biopsy or whatever, right? So I think that it's a game changer in many cases. I kind of get a little bit annoyed as well at times because my cohort of not the whole 2 million are being used almost to strengthen the algorithms for the benefit of everybody. But it's okay because at the same time, we're still benefiting from early detection. So
Yeah.
politics aside,
I
so
think there
at
are.
least our guys are being given the heads up to say, hey, you may have something that warrants further investigation. And don't forget, silicosis can be asymptomatic as well. So you may actually have the progression of illness or a disease, but it may not physically manifest. You may not notice that you have it.
Yeah. I think AI is stepping in everywhere across all of our medical world. I think it's one of the great additions to medicine as we move forward. And as you said, we've got to get enough information into the system to be able to pull the right data out. But early detection using AI, it's one of the examples across medicine that it probably is going to prevent illness and death into the future. And so I mean that's incredible technology. We're just going back to the technology in AI coming out of Australia with the breathing tests. Have you se- do you know much about it? I know you sort of touched on it. The value of it, credibility.
I know a little bit.
Yeah.
The universities that are involved in the research, the universities involved in the research are a good university. They're supported with a lot of funding. In fact, I was going to mention that Australia and New Zealand um, have a lot of really excellent specialists who are really doing fantastic work in the issues of silicosis and occupational lung diseases as a overall. There is actually a lot of research being done by I think it's the Asbestos and Dust Diseases Research Institute in Sydney, and, and they're doing a lot of work on the issue of biomarkers, which you sort of alluded to. So I know that there is a lot more focus happening there, and it sadly seems that Australia and New Zealand are, are really pushing for this. And in fact, there's a lot of money being pumped into the research to try and support and help workers right across the whole region there. So I would say that I don't know enough about it because I'm not in that part of the world. I've only can go on the basis of what I've also seen and read. But I would say that it's definitely looking promising for sure. And it's exciting and
We
it's something that I would definitely want to use as well as the health lead for my ex-miners associations as well.
Yeah, we might have to bring you out on a speaking tour. Talking about great leaders in this area, Dr. Mary Obel, who popped a question in before, but sent something through earlier. So I just want to run this by you. The question is, with new RCS regulations coming into effect, how can businesses strike the right balance between meeting compliance requirements and building a proactive culture of health and safety that goes beyond minimum standards? It's always that balance. How do we get that right balance?
I have a I, yeah, I have a slightly different view on it because when I first trained in occupational health and safety, I trained as an inspector, as a safety inspector. Then I got trained by the UN as a labor inspector and as a factories inspector. So been, I've always had that enforcement background as well as my practicing skills. Law owns a ceiling of expectation, and I always believe that we should work in the domain of best industry practice. We should be stepping above those standards that have been set for us. They're kind of set for the, I know it's going to sound a bit weird, but they're kind of set for the less performing types, the organizations that have to be pulled and cajoled into compliance. But if you're in industry or you're a professional in what you do, they're not what you're aiming for. You want to exceed that and really progress forward. Those sorts of things only really work by example. They have to understand that good health is good business. You don't want to just have regulatory compliance. And then when you have the involvement and the support of the workforce or the trade unions, they're involved in the review of documents and procedures. That all goes a long way because quite often, and it happens all the time, documents are produced, they're a cut and paste job. Somebody used, SOP or SWP somewhere else. They just bring it along, cut and paste, and now it may not be, or it may be. You never know. It might be perfect, but common sense dictates that every situation, every work environment is going to be different. Different people, different premises, different processes, different circumstances. And maybe the atmospheric temperature and pressure is different in that part of the country. There may be more relative humidity. There may be more of a certain type of quartz, the quality or the percentage of the quartz that's present in that facility will be higher, right? So I would definitely say that everything needs to be done with real thought and understanding of what you do. What are the hazards? If you don't know what the hazards are, you can't fix them, right? And if you think that you're doing the right job, well, how do you know you're doing the right job? Any kind of occupational illness or disease, you don't really want to mess around with it. You don't want to chance it. There's some statistics from around the world talking about global burden of disease. About 2 point something million people get killed every year right? Around the world in work-related accidents, but it's 8 times that. In fact, more than that, in terms of occupational health and diseases, people get exacerbated or something happens, but their health changes, and therefore it could be mental health, physical health, and it can lead to further complications. So talking about regulatory compliance, yeah, I get it. You want to tick a box to say you've done it, but I think it's more than that. I think you need to really use it as the absolute basic minimum mark and aim for best industry practice and beyond.
Yeah, it's interesting on the Q&A we've got going here. Bernie's mentioned we need more education in workplaces, especially for the SMEs regarding silica exposures. I'm starting to think maybe we're going to bring you back here and run something a little bit different, a little bit more specific. Not enough like hygienists, not enough health nurses. I think we're going to bring you back and do a bit of bit more educating. I want to run another question by you. This was from Fiona Performant. How are we better able to capture, it's a great one, transient workers such as truck drivers who load and deliver the crystalline quartz/silica for various industries? I think that's an interesting one.
That's a really question.
So
That's an
I'll tell you
excellent
that
question.
one of the things we've designed through my health record is this ability to capture the health record, the testing, and be able to move that between organizations, give the employee the option to be able to pick up their file and move it. Just thinking about drivers and they're moving between different organizations, being able to bring the data across. We've designed that out through my health record because we see that as one of the biggest issues, employees moving through their life and the issue of actually not being able to move your health with you along that journey. So we've definitely designed that out, but it's a great question from Fiona. I mean, what are your thoughts around that? People moving roles.
Well, yeah, I mean, I'll give a practical example of actually a silicosis or silica awareness issue that occurred on a mine in northern British Columbia, not far from where I am at the moment. Um, One particular day, I heard that all of the truck drivers decided to stop driving, and I remember asking, well, is there a particular reason for it? And they said, well, apparently they're all dying from silicosis. I said, okay, stop, time out. Who's dying from silicosis and how did they determine that they had silicosis in the first place? And so what had happened was basically somebody had mentioned amongst the guys talking, oh, all of the dust that's around is going to cause you to get cancer, and you all have it. You don't know you have it. And I remember the mine panicking because they were essential in for the operations and said, Nayab, we know you're not, we know this is not your preview to do this, but do you mind having a chat with him? I said, no problem. I went, the whole room was full of these truck drivers. And I said, just ask me whatever you want. And, cut a long story short, we were talking. I said, look, guys, there are things that you can do that can avoid you from getting silica dust exposure anyway. How about you close the cab window? How about you change the air filters regularly? How about you use a HEPA filter vacuum to clean up the dust in your cab from your dusty clothes and also the seats and the ground as well? Things like that, simple steps and simple measures. And then we did talk about the issue of lungs and health and stuff. A lot of the guys smoked. They smoked chimneys. And I said, well, you know what? You're more likely to you're more likely to succumb to issues associated with smoking. Yes, you're exposed to the dust. Yes, you're exposed to a fair bit of the dust, but you don't have to be. There are ways of controlling it. So, it's a tough one to answer. I don't know if I've got an answer for it today, but I definitely think that it warrants a further conversation for sure.
Yeah, sure. Bernie Cameron's brought up a good point here regarding they've been using LVCT scans for their silicosis monitoring
Mhm.
versus X-rays. You're saying the difference in comparison is chalk and cheese. Can you define the difference? Do you understand the difference? Can you talk more to that or
Um,
no? I'd love. It would be good
I
to have
don't.
Bernie to be able to.
Yeah, it's a good question. I don't sort of, I'm not on the analytical side. I'm more on the occupational health spectrum side of things and occupational health and safety. So I don't want to give the wrong advice.
Okay.
I'd just be
I'm going
guessing
to
there.
ask you,
That's right.
thanks, Bernie. We need to know more about that. So I'm going to ask you just regarding, I'm just going to dive into technology for a second.
Mm,
What do you see out there? Mike Othrick have gone and built this platform to enable organizations to manage their health data better, to manage recalls, reminders, health surveillance, all the testing that goes within it. What have you seen globally that has worked well? I know that you've obviously seen our software and you're a global partner of ours, but what have you seen globally to assist organizations to make sure they're managing and utilizing their data well, and not being caught on spreadsheets, and what's been useful, even for you in Africa?
yeah, I think overall, worldwide, most of the data gathering, data capture is Excel. And reports are captured in PDF format, and you can't really do much with that information. You may be able to pivot some of the data and extrapolate, graphs and charts and things of that nature, but it doesn't really help so much. And I'll tell you why. Data is static. It doesn't really capture where you were exposed to issues or the background history. It just sort of captures something at that given point, at that given moment in time. I think we've frozen again, so I'll just hold on for a
I can
moment.
still hear you. I might look frozen, but I can still hear you.
Okay, you're back. Can you
Yeah.
hear me?
I could hear it
Okay,
all. Keep going. Yeah.
okay, sorry. So you, there is software out there. There are different platforms that exist, but a lot of them are cost prohibitive. They're really intended for real big players, and as I mentioned, most organizations are small, medium enterprises, or they may not have necessarily the type of budget needed to acquire this high-end, high-spec type software solution. I find that uh, quite often that information is very static in silos. It doesn't overlay with, say, exposure monitoring. Okay, this individual has had a diminished lung function over a period of time. Oh, and by the way, we change the process or we change an activity or that individual is now doing something different. You can kind of correlate the two together in shape or form. What I've done, I've used a very simple method. Um, I just received a grant. Actually, I'll explain. I'll bring it up. I received a grant from the American Industrial Hygiene Association just a week or two ago to do what's known as body mapping exercise. And with body mapping, it's a concept where you have a body form and then you give the person a pen and say, mark where you feel pain. We used to refer to them as ouch maps. And okay, I get pain in my neck, I get pain in my lower back, I get pain in my right knee, etc. You mark it off. That gives you a rough idea of the profile of an individual's health. It could also indicate mental health because they've put, against their head that they get dizzy or they have fatigue or stress. You can overlay that information and then you can identify trends as well. So you suddenly see that there are, out of 27 guys and girls, 14 of them have indicated that they're experiencing chest tightness. Okay, why? Then you can zoom in and then you can use that information to see where do they work? What do they do? What kind of activities are they involved in? So
Mm. Okay.
that's the kind of technology. It's not really technology, but that's the methods we can use in the global south and in countries which are resource deficient. I like the software that you guys have because I think I reached out to you actually because I was interested in the product for my own needs. Um, because it follows the individual. It doesn't stay with the organization. It follows the individual's life cycle. And I think that's fantastic because we're today I'm here I'm working here in British Columbia right now. I live here, I work here, but my career before me, 35 years, I've worked in 60 countries. Yes, 60 countries, right? I've worked in multiple organizations. I've been exposed to all sorts of crap, right? I would like to know what my health status is. not just think, well, maybe when I worked for so and so company that I was exposed to something and okay, now I'm sick. Was it their fault? I don't know. I like the fact that you have these modules on occupational hygiene, you have occupational health component, and it follows the individual.
Yeah,
That's
Harry's asked that question. He wants to understand a little bit about more. I didn't want to make today a more marketing experience. I really want to get some information on Silica,
sure,
and
sure.
some of your expertise, of course. But I think just Harry, just to respond to your question about what my health record is, effectively, we've seen in the market for many, many years that health providers come and go from organizations. They have their own software platforms. They're typically not good at building software. They own the software. It becomes very hard to extrapolate that data. And the other challenge we've always seen is if an organization has a pre-employment provider, a health surveillance provider, an hygiene provider, typically they might be different providers with different systems. So my health record has effectively been built to fill that gap between HR and workers' comp, if that makes sense. So there's great HR platforms out there that give candidates a better experience. 20 years ago, they hit the market and they give a better experience for candidates. They don't manage health data well. There are safety systems out there that do a great job around the safety space, but don't really manage health data that well. There's a whole gap in the middle. And we've always seen an issue where there's a lack of connection between the first medical assessment that's done, which is a pre-employment, all the way through the journey and life cycle of an employee. That data is spread amongst multiple individuals across an organization and it's never well collated. So my health record is there to fill that market space and to bring all that data into one place, all the health data into one place, not in an uploadable way where you're uploading a PDF, but more where it's got a user interface for all medical and health practitioners and the data feeds in so it's collecting data points. And as we look to the future, and we know AI is coming in, we need to understand the data, not just have PDFs uploaded, but what is the data really telling us? So My Health Record's built so that every data point is actually captured. And so that in years to come, we can actually utilize that data from the moment you have a pre-employment, whatever your blood pressure might look like at that point, as an example, all the way through to the moment you may leave an organization. And then if by choice you want to take that data, you can take that data to the next organization. But we'll send information out about that after, of course. What I want to do is, we're running out of time now. We've clearly caught you in a hotel room today.
Yeah.
Every time I speak to you, you seem to be in a different place, actually. We had you in a car once. Now we've got you in a hotel room.
Nice.
You are a global man in this space, and I'm hoping we can bring you back again to have a further conversation.
It'd be
Um,
my pleasure.
Anyone that's got any questions, please feel free to send them through. We will come back to you. We'll get Nayab to answer them and come back to you, and we'll send a document out to everybody. But what I want to do is thank you, Nayab, for your time today. Thank you for the work you're doing. We only live once, and you're committing a fair bit of your life to improving the lives of others globally, with a focus on Africa and the needs in Africa, which is actually incredible. And we're grateful to it and the impact you're having across this industry. So thank you to everyone for dialing in today. Conscious of time, we will come back with more information in due course. And to Nayab, a special thank you to you. All the best and take care, everyone.
Thank you, guys. Have a
Thanks,
lovely
Nayab.
day.